Today we're going to be talking about autoimmune disorders, and in particular, inflammatory bowel disease of the gastrointestinal tract. The gastrointestinal tract comprises everything from the mouth all the way through down to the anus, and includes certain other solid organs such as the liver, the gallbladder, and the pancreas. The function of the gastrointestinal tract is to ensure that the intake of all food and liquids is processed, which is very important because your body needs nutrients from food and drink to work properly and to function in a healthy manner. Inflammatory bowel disease affects this function and has many other undesirable effects on the body. Autoimmune disorders occur when the body's immune system inappropriately attacks the body's own healthy tissues. These conditions may be restricted to specific organs, such as autoimmune thyroiditis, or they may involve a particular tissue that is present in different parts of the body. For example, Goodpasture syndrome, which is an autoimmune disorder of the kidneys and the lungs because it affects the basement membrane. There are more than 80 different types of autoimmune diseases, and their onset is typically slow and sometimes occurring over the course of many years, and their symptoms are often nonspecific, with general things like fatigue or malaise and fever as the presenting symptoms. Inflammatory bowel disease is just one of many autoimmune diseases. In terms of inflammatory bowel disease, this is really just the general name for diseases that cause chronic inflammation and irritation in the intestines. It is also known as IBD. The most common types, and the types that we are going to focus on in today's presentation, are ulcerative colitis and Crohn's disease. IBD can affect the entire length of the gastrointestinal tract, from the mouth to the anus. It can cause very mild impairment with almost no impact on the life assured, and it can also cause severe impairment and even early mortality in severe cases. IBD, like most autoimmune diseases, follows a relapsing and remitting course, with regular follow-up and treatment received being very good clues as to how severe the condition is in an individual. Genetics, of course, play a very important role, and 15% of people with IBD actually have a first-degree relative with IBD as well. This is further supported by studies which have demonstrated that there is up to a 50% concordance in monozygotic twins. The fact that only 50% of monozygotic twins show concordance also means that the environment is very important in the development of inflammatory bowel disease. This is both in terms of getting the illness as well as controlling it. Now, an abnormal immune response in the GIT is the basis of the pathophysiology behind IBD. And although the mechanisms are similar, Crohn's disease and ulcerative colitis are distinguished by history, investigations, and lab findings, which include histology. The disease causes chronic inflammation, with ulcers, fistulas, and strictures developing over time in the gastrointestinal tract. In order to understand how IBD affects the gastrointestinal tract, we need to understand a little bit of the basics of the anatomy of the GIT. Now, the intestines are essentially lined by a mucous membrane which forms small little tongue-like structures called villi, and these are essential for the absorption and partially for the digestion of nutrients. In order for the GIT to function normally, you need an intact mucosal surface. It is very important to understand what chronic inflammation caused by IBD does to the gastrointestinal system. In order to understand this, I'm going to discuss a few basic terms regarding the complications of IBD, and these are ulcers, which are areas in the GIT, and specifically the small intestine and large intestine, where there is a break in the mucosa, which, like I mentioned, is the lining of the GIT. These often cause bleeding and affects the ability of the GIT to absorb nutrients. You then get fistulas. Sometimes ulcers can extend completely through the wall of the intestine, and this is what causes a fistula to form. And it basically is an abnormal connection between different body parts. In most cases, in IBD, a fistula can form between two parts of the bowel itself, or it can form between a part of the bowel and another organ. The next important concept to understand is the formation of abscesses. Now, an abscess is simply a collection of pus that is built up within a tissue, and these abscesses, in the case of inflammatory bowel disease, develop as a result of fistulas and ulcers getting infected. The last concept to think about is fissures, and fissures are basically deep tears in either the skin or the mucous membrane. When thinking about inflammatory bowel disease from an underwriting or claims perspective, there are a number of factors which one needs to consider. Firstly, the severity of the condition, which can range from mild to moderate and even severe, as well as the age at diagnosis, where generally the younger someone is diagnosed with IBD, the worse the prognosis. The time since diagnosis is also important because the longer someone has the condition, the more chance there is of complications having arisen, as well as the history of relapse and recurrence of the condition, where an increased number of relapses or recurrences of the condition indicate a poorer prognosis. Now, underwriting decisions can be standard rates, loaded rates, exclusions, or outright declines, and this all depends on what type of cover someone is applying for. From a claims point of view, claims decisions will depend on what benefits are being assessed. We will now look at Crohn's disease and ulcerative colitis as separate entities, but what you will notice is that there's a lot of similarity and overlap between the conditions. Talking about Crohn's disease. Crohn's disease affects the terminal ileum, which is the last part of the small intestine, as well as the beginning of the large intestine predominantly. But different parts of the small and large intestine can be affected as well. The characteristic presentation in Crohn's disease is abdominal pain and diarrhea, which may be associated with rectal bleeding, fever, weight loss or anorexia, nausea or vomiting, malnutrition, vitamin deficiencies, and generalized fatigability. In general, people will be diagnosed before the age of 30 or after the age of 60. However, you can get variations of this, and this is just a general rule. What is important to remember as well is that smoking imparts an increased risk of developing the disease and also tends to worsen the symptoms that one experiences. In terms of complications of Crohn's disease, the following complications can occur and will affect underwriting and claims decisions. First of all, ulcers. Chronic inflammation can lead to ulcers forming, which again is a break in the lining of the mucosa of the GIT, and this can occur anywhere in the digestive tract, including the mouth and the anus, and everything in between. A very severe complication, which can arise from Crohn's disease and normally happens in severe cases, is a case of bile obstruction, which can arise from the wall of the intestine becoming very thickened and forming a lot of scar tissue. In terms of other complications, malnutrition is also very common because of the GIT's inability to process food normally. The way this will present is often with chronic diarrhea and abdominal pain and cramping, which makes it difficult either for the person to eat or for the intestine to absorb enough nutrients to keep a person nourished. Another very serious complication is the increased risk of colon cancer. It is very common to see people with long-standing Crohn's disease develop colon cancer, and this is often a result of the chronic inflammation and scarring that occurs. Other health problems which can be associated with Crohn's disease include skin disorders, osteoporosis, arthritis, and gallbladder or liver disease. There are also risks from taking chronic medication. So, how does one diagnose Crohn's disease? The short answer is that there are many tests that can be used to diagnose it, and there's no single one test that is used above another in order to make an accurate diagnosis. Firstly, blood tests can be used to check for anemia, inflammatory markers, and other autoimmune markers. Stool tests can check for blood in the stool. X-rays and CT scans, with and without contrast, can check for damage to the bowel wall. MRI use is becoming increasingly more popular and is also a very accurate mechanism to diagnose Crohn's disease. And probably the gold standard is endoscopy, where classic skip lesions are identified. Now, skip lesions are simply what doctors see when they do an endoscope, and they see that there are different parts of the bowel which are normal, and they are interspersed with areas of ulceration or fistula formation. You can get lower endoscopy, which essentially boils down to colonoscopy, where biopsies of any lesions identified will be taken. And you also get upper endoscopy, which is used to assess the stomach and the early part of the small intestine to assess if the extent of the lesions goes beyond the normal end of the small intestine and beginning of the large intestine. Treatment depends on the symptoms a patient is experiencing. Mild disease can occur in most people, and this would be classified as someone who doesn't have anemia, who only really uses antidiarrheal medications. They may use some non-steroidal anti-inflammatory medications such as aminosalicylates, and they usually only have disease that involves the small intestine. People with moderate disease would potentially have a mild form of anemia or no anemia at all, and treatment would often include frequent corticosteroid use in addition to the treatment that I mentioned before. Treatment can also include the use of immune modulators such as methotrexate, cyclosporine, and azathioprine. In addition, the disease is found in the colon as well as the small intestine, but is not widespread. These individuals may have had some surgical procedures, which would have been to correct the formation of strictures and possibly fistulas. However, the overall picture is not the most severe that you can get. In terms of severe disease, generally these people have tried a range of therapies and have often had multiple surgeries, and they are often using what we know as biologic therapies, which are essentially specific drugs that target the autoimmune nature of the disease and is generally looked at as a last resort of treatment. Often, like I said, these people have undergone multiple surgeries to treat fistulas or strictures, and they may have even had even more major surgery, such as the removal of small or large sections of the small or large intestines. People may also end up with a permanent ileostomy or colostomy. Malnutrition is also very likely to be present with people having very low BMIs. Of course, from an underwriting point of view, these would present very poor risks, and from a claims point of view, depending on the benefits, are very likely to be able to claim on these events. Next, we'll look at ulcerative colitis. Now, ulcerative colitis affects mainly the large intestine. The characteristic presentation in ulcerative colitis, again, is abdominal pain and diarrhea, and again, it may be associated with rectal bleeding. There can also be fever, weight loss and anorexia, nausea, malnutrition, vitamin deficiencies, and can also involve joint pain, skin rashes, or even eye irritation, which speaks to the autoimmune nature of the disease. In terms of age of diagnosis, generally people will be diagnosed before the age of 25 or after the age of 55, and there are slightly more women than men diagnosed with the condition. From a complications point of view, people with the disease can have severe bleeding as well as dehydration and malabsorption. Because of the ulceration and fistulization, you can also end up with a perforated colon, which is a potentially life-threatening complication, as well as osteoporosis, inflammation of the skin, joints, and eyes, as well as, again, colon cancer being an increased risk. A rare complication is known as toxic megacolon, and this is essentially when there is a functional obstruction of the bowel because the bowel has actually stopped working. There's also increased risk of blood clots in the veins and the arteries. So, how does one diagnose ulcerative colitis? Again, there are numerous tests that can be used, and there's no one test that doctors will use to make a diagnosis of ulcerative colitis. Blood tests can be used to check for anemia and inflammatory markers and autoimmune markers. Stool tests, again, can be used to check for blood in the stool. And then X-rays and CT scans, again, with or without contrast, can check for damage to the bowel wall. In the case of endoscopy for ulcerative colitis, normally the endoscopy is only lower endoscopy, and this, again, refers to colonoscopy, where biopsies of lesions that they identify are taken. From a treatment point of view, treatment depends on the symptoms that a patient is experiencing. If we were to consider mild disease, these individuals would probably not have anemia. Their disease may even be inactive with very rare recurrences or relapses, and they will only be on non-steroidal anti-inflammatory medication such as sulfasalazine, and the disease would only involve the left side of the colon. If we were to consider moderate disease, we may find individuals with some form of anemia. Treatment would often include corticosteroid use, either present or past, in addition to that mentioned above, and can also include the use of immune modulators such as sulfasalazine, 6-mercaptopurine, and azathioprine. The disease would often, though, be widespread throughout the colon. If we think of then severe disease, these would then include people that are using biologic therapies, which, remember, are therapies that are used to specifically target the autoimmune nature of the disease. Often people have undergone either single surgery or numerous surgeries, which could be to treat megacolon and other complications that we've mentioned before. And again, you could have situations where people have actually then been treated for colon cancer, which has arisen as a result of ulcerative colitis. People may end up with an ileoanal reservoir as a result of potential bowel resections, or they could also end up with permanent ileostomy or colostomy. Malnutrition, again, is very likely to be present with people having low BMIs because of the severity of the condition. From an underwriting and claims point of view, and things to consider, IBD is a complex entity, and diagnosis is based primarily on extensive investigations, and chronic treatment is often required, with long-term follow-up. Underwriting this condition is often not possible with up-to-date medical information from the treating specialist, and from a claims assessment point of view, this condition must include the review of up-to-date medical information about the severity of the condition in line with the modalities of investigation of this disease entity. In summary, IBD mainly refers to Crohn's disease and ulcerative colitis. These conditions collectively affect the entire gastrointestinal tract, from the mouth to the anus. IBD results from immune system dysfunction, being an autoimmune disease. Differentiating between the two main entities of IBD requires invasive investigations and usually a histological diagnosis by way of biopsy of the gastrointestinal tract. Complications of IBD can be devastating, with significant impact on mortality and morbidity.